so we are gonna start now questions about maternal and pediatric health. We have 30 questions in this one. We will see how we will go. We are also gonna meet at 10 p.m. EST New York time for renal and urinary SATA questions. So if you please write down that time, it will be great. And then we can start this one. Okay, a nurse is providing teaching to a newly pregnant patient at 8 weeks. Which food should nurse recommend to increase folic acid intake? So we know why we need folic acid, just to prevent the neural tubal effect. So B is vitamin C, red meat protein, calcium for dairy products. Thank you, Acharya. Okay, so what is correct answer, guys? A? Yeah. Okay, so we definitely have folic acid in leafy green vegetable, but it is also present in citrus fruit, okay, like orange and whole grain. Yeah, so A, B and C is correct. Okay guys, so red meat doesn't have the folic acid, and dairy product also don't. So A, B, C all are correct. Okay, they are not primary source of folic acid, but we can go with A, B and C. Okay, let's move to question number 2. A patient at 10-week reports nausea and vomiting. Which nursing intervention are appropriate? What about question number 2, guys? ABD, yeah. So morning sickness is especially very common in first trimester, so we need to have appropriate intervention. Okay, yes Acharya, B can be possible. Okay, so A, eat small frequent meal because it's gonna prevent empty stomach and maintain appropriate blood sugar levels. So A is good, small is always good. Drink fluid between meal. Okay, so why we need to drink fluid between meals? Because if we are not drinking the fluids, this is maternal. Okay, yeah, so drink fluids between meal. Okay, because just to avoid the gastric distension that can increase the nausea, so we can do B also. Avoid spicy food. We know dehydration, just definitely. So spicy food and greasy food is very hard to digest, and that can trigger nausea. So we need C can be the possible intervention also. And just T to King, B is correct. Okay, if patient is having fluid between the meal, it will help to avoid the gastric distension. Okay, what about D, guys? Take antiemetic. Is D correct? What about D, guys? Yeah, because it is prescribed by the provider, and patient can take it if it is prescribed, and for nausea and vomiting. Okay, so they can have that one. Yeah, drinking between meals can induce vomiting. drinking fluid between also can be helpful. Okay, it can be helpful. Anyone else? Anyone else thought? Anyone else? Yes, Acharya, but the thing is that here also, when we drink fluid between the meals, it helps us to make our stomach bit full, and patient don't eat that much. Okay, yeah, okay, so that's why. MSN you can share straight. There is a sharing link at bottom down here, so you can share with anyone, please, or you can share the account Narsingi, this account. Okay, thank you, really appreciate. Okay, drinking coffee every morning. What's gonna happen with drinking coffee every morning? We know coffee is a gastric irritant, yes, and that's not gonna help. That's not recommended. The water alone can, yeah, the water alone is different, but yes, but the thing is that when you are having between the meals, it is helpful. Okay, because even empty stomach can trigger nausea. Okay, empty stomach can trigger nausea, so you don't want your stomach to be empty and distended. That's why you can have fluid between meals. And everyone, honestly, everyone have different triggers for nausea and vomiting during the pregnancy, so it's good we assess those one and we recommend it accordingly. Okay, thank you for following, guys. Let's move to question number 3. So this is all maternal question. Okay, if we will have pediatric question, they will refer it. Okay, a patient at 12-week ask about safe exercise during pregnancy. Which should the nurse recommend? What about these one? Which one is regular and safe exercise? A, D, yes. A is good. Walking, low impact, accessible, patient can do anytime, so A is good. Swimming, is swimming good during pregnancy? Yes, Akisa, definitely. Yeah, swimming is full body workout. Okay, yeah, okay, so swimming is good. Do you think contact sports, anything they were doing regularly prior to pregnancy, it can change, especially here for book club. Like if somebody is doing contact sports, like we having suppose rugby, boxing, and those kind of sports, we don't want to do that. Yeah, what about prenatal yoga? That's always recommended. Yes, D is good. Yes, okay, it will help to increase the flexibility, strength, and also help in the relaxation, so that's good. And we don't wanna encourage patient to do heavy weight lifting, because that can cause injury, that can cause fall, that can lead to overexertion, so this one. Alrighty, let's move to question number 4. So a nurse is reviewing routine prenatal lab. Which result require follow-up. Okay, this is for safety. So anyone? And thank you guys who just joined us. We every day we do these questions, and most of these questions are uploaded on YouTube. Narsingi, if you haven't been on our previous live, you will find our last live session on YouTube. Just search Narsingi. Okay. Okay. ACD, BCD. Yeah. Let's do A. Definitely, if someone is having positive HIV test, they require the immediate follow-up, because we need to start the antiretroviral therapy that can prevent the mother to child transmission, like we we want to treat it. Positive rubella, IgG. What about B, guys? If somebody is having IgG, is it good or is it bad? Do we need to worry about that one? It's antibodies, okay? It's antibodies. Yeah, they are immune. Yes, thank you here for book club. Okay, so this is not concerning part. This mean it's good finding. It's a patient is immune to rubella, so no follow-up is needed. Yeah, nice. Thank you for being here. Okay, what about hemoglobin? So what is the normal range for hemoglobin? C? Yeah, we will do C also. We will definitely do C, because this is indicating anemia. This is less hemoglobin. We are expecting like 110 to 140, you know. So this need to require immediate follow-up. We can support mother with iron supplementations and diet assessment. So this definitely require yes. Yeah, okay. What about the positive hepatitis B surface antigen? So this is the thing, because that was immunoglobulin, that was antibodies, and now we are having antigens. So definitely yes. Okay. So D is definitely yes. And because to newborn, if you can correct me here for book club, we need to administer hepatitis B immunoglobulin to baby immediately after birth, just to prevent transmission of hepatitis B to baby. Thank you, Tiff. Thank you, RN mom. Negative syphilis serology. What about that? Is it good indication? Yes, immediately. Yeah. So if somebody having hepatitis B surface antigen, then after birth immediately we need to give hepatitis B immunoglobulin to baby. Okay. Okay, so this is actually good finding. This is normal desired result indicating absence of syphilis, so we don't need to worry about this one. So this is good. Okay, let's move on to question number 5. Actually, we started the renal one, bit difficult one, but there was too much information on one page to show here, and it was not showing properly. So we will do renal at 10 p.m. EST, New York time. Okay. Okay, question number 5. The nurse is teaching a patient about warning signs during pregnancy that require immediate medical attention. Which should be included? All but D. Yeah. ABC. Nice. Okay, vaginal bleeding, definitely, because this can be sign of miscarriage. This can be sign of ectopic pregnancy. This can be sign of placental tissue, placental abruption, placental previa. So definitely A is correct. Okay. And what about severe abdominal pain? Why we do have severe abdominal pain? What it can indicate? All glory. Yeah. Abruption. Yeah, it can be ectopic pregnancy also. It can be placental abruption and maybe preterm labor. Yes, definitely. Yeah. Trauma. Yeah. Swelling of face and hand. So swelling of face and hand, that's typically we see in, yes, because this is one of the sign of preeclampsia. So especially we need to see if it is accompanied by other symptoms or not. So make sure we assess the hypertension and how patient's blood pressure is doing. Increased fetal movement. Do we need to concern about if fetal movements is increasing? I think it's more concerning if it is absent or decrease. Yeah, so that's why we're gonna say no to increase fetal movement. Okay, and distress can be there, but firstly, like, the mother should have warning sign for those distress also. Okay, yeah, because sometimes, like, I have seen patient like who have even eaten more sugar, and sudden surge of, I think, sugar in the body, in the blood, will increase the fetal movements also. There can be some normal cause. So because if we will stay in context of questions, we can definitely assess it why it's happening, but it's not always warning sign, and it does not require immediate medical attention. Okay, and what about severe headache? Will it be related? We stand to stress to protect. Yeah, so increase is good. Yes, it is. Thank you, Tiff. It is sign of preeclampsia, severe headache. Okay, because ICP is increasing, blood pressure is going too high, so we definitely gonna look after E2. Okay, let's move to question number 6. So a nurse is caring for 20-week pregnant patient. Which finding are normal? So we are in second trimester now. So yeah, because we are doing our first session on maternal health here, so that's why I just kept it very short, small, and easy. But next time we will do a bit more case studies. A B C D A B C. Yeah, so quickening, because most of the time typically is felt between 16 to 20 weeks, so A is correct. So it's 20-week pregnant woman, so definitely A is correct. Fundus at umbilicus, is it correct? Because typically we need it at the level of, what is quickening? Fetal movements felt by mother kicking. Yes. Okay, at the navel, so B is good. Yeah, and what about fetal heart rate? All except D. Yes. Yeah, fetal heart rate is normal also. 110 to 160 is normal. Blood pressure 160. So this is because we already discussed preeclampsia before. So if this is what we are getting into the patient, this is the reading that is indicating the potential risk for preeclampsia, so we will assess that one. Okay, fundal height 20 centimeter. Yeah, yes. Okay, so what happen usually, if here for book club you can correct me, after between 20 to 32 weeks, fundal height usually resemble the correlate with the gestational week. Okay, so if it will be 20 week, it is 20 centimeter. If it is 30 week, it will be 30 centimeter. That's the one they have teaching us. Yeah, so usually they say like it's correlate with the week. Okay, yeah. Okay, yeah. Question number 7. So a patient at 22 weeks is undergoing an ultrasound. Which findings would be expected at this stage? So what we can see at 22. Fetal heartbeat visible. So because fetal heartbeat is usually visible around 6 to 7 weeks, we can start getting that heartbeat. So that's gonna be very good sign. If it is not visible, if it is not there, not good. Okay. Sex of baby identified. Yeah, because genitals are well formed by 22 weeks. Okay, so it can be identified by ultrasound at this stage, so this is expected. What about fetal movement felt by mother? C. Yes, I'm bit, because fetal movement felt by mother is mostly about quickening that we talk about, and it's subjective. In ultrasound it's gonna be hard. Okay, it's gonna be different in ultrasound, and because we can't see those movement like that, there will be some robust movement anyway. um, Everyone agree with that, or can we see those fetal movement in ultrasound? Because if I'm answering this question, I'm gonna say C wrong, but those are subjective, so we are just uh, yeah, the mother do feel, but this the question, because we are studying the NCLEX questions, so they usually trick us. Okay, yeah, mother can feel, definitely mother can feel, but this question is about undergoing ultrasound and which finding would be expected. Okay, so that's why in context of NCLEX and in context of this question, I will say no to this one, because NCLEX is different. So but definitely by this time from 16 weeks onwards, mother can feel it, and it's subjective. We are not gonna, yeah. Okay, fetal lung fully mature. What about D, guys? When we are expecting lungs to fully mature, around with how many weeks? Yeah, definitely no. When we, yes, 36, 37. Yes. Okay, they are typically mature around 36, 37. Yeah, this one is US, Canada, and NCLEX, so it's different. Okay, guys, let's do next one. So, a patient at 24-week is being educated about gestational diabetes risk, which are the risk factor. Which are the risk factor for diabetes? On Chitukum, basically, like most of the time, most of students do NCLEX for them. I know we do have in Australia, we do have in New Zealand, we do have everywhere it is called, but this is just because Pearson view always have same kind of structure everywhere, so it's very resemble all over the place, and especially things not gonna change, knowledge is same. Okay, is yes, is definitely yes. Obesity yes. Excessive body weight, because we know obesity can cause insulin resistant, and that can increase the risk of gestational diabetes, so definitely A. Your question, are they from Pearson? No, these are the question that I made myself, honestly. Family history of diabetes, Pearson doesn't provide these kind of questions. Okay, so if there is a genetic predisposition, definitely uh, it's the key risk factor. Okay, and what about maternal age more than 35? Does it change anything? It's not easy. It's not easy. The last question booklets that I opened, the one I showed you for renal one, that is exactly you're gonna see in NCLEX. C is yes, because like it's not the only but there is a finding that insulin resistant chances increase in human body as we age. Okay, so it's similar in everyone. There are more chances of insulin resistant as we age, so it can be another indication. Okay, and what about macrosomic infant? If mother already had previous baby weighing more than 4,000 gram, yeah, yes. Okay, this is one of the strong indicator of prior what we will say, sometimes they don't have, yeah, sometimes they don't have the diagnosed gestational diabetes, but this can be the good indicator. This can be the good indicator. Okay, so we will take yes. And what about smoking, guys? Does smoking have any relationship with gestational diabetes? Yeah. Mhm. Smoking does have a lot of other effect, but it is not a direct risk factor of gestational diabetes. That's what I think. If please you are saying yes, can you give bit of rationale so we can think? Because what I have learned, like smoking is not gonna cause diabetes. It's not the direct factor that is responsible to cause diabetes. Yeah, yeah. How maternal age affect? We just talk like, it's not just maternal age. Everyone, while we age, there are higher chances of insulin resistant. Okay, so that's why that is one of the another reason that we can see more insulin resistant. Same like if somebody is having obesity, there is higher chances of insulin resistant in obese person, so that's why it can increase gestational diabetes risk. Yeah, yeah, it's about the hormones, yes. Okay, significantly increase your risk of developing type 2 diabetes by 30 to 40% risk factor. But that's why I said like because it's a bit controversial. It is like what I will say, it's not direct like causative agent. That's what I'm thinking, because it's not. Yeah, because in the other one definitely it will help to if somebody is smoking, there are other chances also correlating, and they can cause the insulin resistant, I think so. um, but not just smoking, not just smoking. Okay, if we will go with the data, there will be definitely, if somebody is smoking, there will be other um, correlating issues also with the same risk as family history. Yeah, yeah. Okay, but feel free to happy to change it, because everyone have their own options, and it's good to learn. And definitely, I mean, I usually post all my live recording at YouTube. So if you can search nursing on YouTube, all of these live recordings are there. Okay, previous also. So you guys can find these questions over there. Okay, so the nurse teach a patient about iron supplementation. Which instruction should be included? What about question number 9, guys? Yeah, this is our first day doing the maternal. We done med surg, we done pharma, we done prioritization a lot. So this is our first day on TikTok doing maternal health. So take with vitamin C, yes, because we know vitamin C is gonna improve the absorption of iron. So definitely take with vitamin C. And what about take with milk? What's gonna happen if we are taking iron supplementation with milk? Hmm? No, yes, no. It is wrong, uh, because won't dissolve. So iron there, yes, Courtney, thank you. Decrease absorption because there is a calcium in milk. So thank you here for book club, because there is a calcium in the milk and you wanna avoid calcium. Okay, the problem is that there is a competitive absorption. If calcium can inhibit the absorption of iron. Okay, they use the same transport protein in the intestine, calcium and iron, so they're gonna compete with each other. Okay, so if we are taking with this at the same time. Alrighty, let's move to expect dark stool. Is it common? Can iron cause black stool, dark stool? Yes. So this is common and expected sign. Normal, harmless. Yeah. So take on empty stomach if tolerated. Do we take it on empty stomach? Yeah. D is correct. Yeah. Because iron absorption is best at empty stomach. So there is only thing like if it is causing the GI disturbance, upset, then we can take it with bit of food. Otherwise, no. Do you take it with milk? No, Teddy, we don't take with milk. Okay, because that will reduce the absorption. And same thing with avoid taking with antacid. That's correct. um, because antacid does have calcium, magnesium, aluminium. There are three types of antacids most common. so they always reduce the absorptions of medication. So we usually don't give medication with antacids. Okay, and the same rule apply here. For iron supplementation also we're gonna avoid it. Okay. Question number 10. In nurses assessing a pregnant patient for domestic violence, which sign may indicate abuse? Okay, question number 10, because it is very important every time when we see a patient to assess for the safety. Okay, so let's do, guys. What about delay in seeking prenatal care? What about A? Can it indicate there was domestic violence? Yes. Okay, because maybe there is chances of like someone is preventing the patient from seeing the care, seeking the care, because there might be fear like they can go and they can talk about that. Okay, so if there is a delay, always ask why. Is everything good, like if why they haven't seen the, you know, and approach to have a care first. Partner always answering questions, not letting mother speak properly, not giving her chance to speak. Yeah, that can be the sign indicator. Controlling behavior, multiple bruise in various stage of healing. So this is very important in mothers also, but this is one of the typical classical physical sign of repeated abuse, and in pediatrics also. So whenever we see that one, that's always indicating there is something going on. Okay, C. And what about D? Consistent attendance. If somebody is very consistent at attendance, is it good sign? We don't need to worry about that. So yeah, so D can be no. So E is depend. E is like patient appear anxious or fearful. Okay, so this is the one of the thing. Yes, we need to assess this one, you know, like sometime if it is the first time pregnancy, um, and with little less knowledge and support, patient can feel anxious also and fearful about like what's gonna happen, what they are going through, and if they are not getting enough support. But this need to be assessed properly. What is the reason behind that? Okay, it can be domestic violence, so that's why we're gonna take it yes. Yeah. Yeah. Okay, let's do question number 11. So a patient at 32, here for book club, we, because this is our first session only on maternal health, so that's why I just kept it simple. We do SATA question, bit complex one, and but it will come later, because most of us are doing like we go step by step and then we start going to the hardest one. So a patient at 32 week has vaginal bleeding with no pain. Which nursing intervention are appropriate? So if somebody is having pain, less vaginal bleeding, what's going on? What can be the concern? D, ECD. So can this be the sign of placenta previa? Yeah, thank you, Glory. So this can be the sign of placenta previa, because if there is a vagina bleeding with pain, that's always sign of placenta abruption. Okay, so placing on bed rest, is bed rest gonna help us with reducing bleeding? Yes, definitely. Yeah. Yes, Seva, definitely. Prepare for cesarean delivery. What about B, guys? Is it immediate intervention that we need if somebody is having vaginal bleeding with no pain? No. Okay. So if there is a severe bleeding and fetal distress, definitely we will go for the cesarean. We can assess for that one, but not for this one. Okay, perform vaginal exam. Is it one of the indicated thing or contraindicating? No. Okay, so we can't do that because what it can do, it can rupture the placenta and it can increase the hemorrhage. Okay, so yeah, we don't need to do that. Monitor fetal heart rate. Is it priority? D, yes. We need to find out whether fetus in any kind of distress, and if we need to immediately do something about that. And what about obtaining ultrasound? Is ultrasound gonna help us with anything? Yes, because it will be helpful to diagnose, like if patient is having placenta previa, like where what is the location of placenta, and whether patient is definitely having placenta previa or any other thing. Okay, let's move to question number 12. So a nurse suspect placental abruption in a 34-week patient. Which findings support this? So last one was placenta previa. So now we are on placenta abruption. Question number 12. So because it's 34-week, it can be premature abruption of placenta from the uterine wall. So severe abdominal pain? Yes, definitely. Severe abdominal pain is there because placental abruption always come with bleeding and pain. And what about dark red vaginal bleeding? What about B, guys? Yeah, the only reason why it will be dark red, because sometimes it can be trapped behind the placenta, so that's why it will be dark, Kemi, because it can trap there. Okay, and what about rigid abdomen? What about rigid abdomen, guys? Yes, this is the again thing. If blood is trapped there, if bleeding is there, then it will be like hard, very hard, board like. So yeah, so C is correct. Cheeto Kings, because placenta can, the blood can, trapped between the placenta, and placenta can also block the way for the bleeding, so that's why blood will stay inside for a bit long time, and that's why it can get dark. Okay, and what about painless bleeding? D. Is D sign of placental abruption? No, it is sign of placenta previa, so not this one. And what about uterine tenderness? Uterine tenderness. Yes. Okay, E is correct. E is correct. Okay. Especially it will be very tender to touch at the site of abruption. So yeah. Yes. Answer in question 11. So you can have a quick look, Grisha. So just place on bed rest and monitor fetal heart rate and obtain ultrasound. Okay, yeah. Okay, question number 13. So a patient with preeclampsia is admitted. Which sign confirms severe preeclampsia? So blood pressure 170, 110. Yes, definitely. So how much blood pressure we need to diagnose the preeclampsia, and how many time they need to be higher? ABD 3 time, 140, 90 above 2 occasion. Yeah, 160. Yeah, so at least like 2 occasion, at least 4 hours apart, it will be diagnostic criteria. What about protein urea 3 plus? So now if patient is gonna have protein urea, yes, because now patient is going into eclampsia stage. Okay, what about platelet? Is platelet normal or is it concerning? Normal, yeah. 150 to 4,000, 400,000. Yeah. Headache and visual disturbance. If somebody is having headache in preeclampsia, we know we have hypertension. It can be sign of cerebral edema, and then it is key indicator like something is going up in brain. Okay. Maybe why I took C? Because C was normal. We talk about C normal. Yeah. Yeah, it is sign of preeclampsia. Yeah. And what about, yes, yes, definitely I just changed the C. Hyperreflexia. Hyperreflexia. Yes. Yeah. Because if somebody is very if we are seeing like someone is agitated, bit restless, hyperreflexia, it is sign of CNS irritability, so E is gonna be correct here. Okay, let's do question number 14. We have 30 question only in this one, and then we will come 10 p.m. New York time EST for renal. Okay, renal and urinary issues. Okay, a nurse is teaching about warning sign of preterm labor, which should be included. And I will post this video on Nursingy's YouTube. All our previous lives are getting posted there also. So thank you everyone who follow us there here. But please search Nursingy on YouTube and support me there also. All but E, yes. Okay, low back pain. This can be sign of uterine contraction. So low back pain can be correct. What about pelvic pressure? Is it classical symptom? Baby is pushing down, the feeling. Yeah. Okay, so pelvic pressure is gonna be warning sign of preterm labor too. And if C, what about C? It's regular. So uterine contraction, when it is regular, is always indicating the labor. Yeah. What about D, guys? Sudden gush of fluid. Why we can see sudden gush of fluid? In premature rupture of membranes. Yeah, nice. And what about fetal movement? E. Yeah, yes, user. Rupture. Fetal movement. Is it normal? No warning sign? Yeah, and we expect that. Nice. Question number 15. The nurse care for a patient receiving magnesium sulfate, which finding indicate possible toxicity. So we know we done magnesium sulfate in our last pharma live. We know it is one of the central nervous system depressant. So yeah, absent D10 reflex, almost all, hopefully. Okay, definitely, because it is CNS depression, it can diminish, it can make it absent. Okay, what about respiratory less than 12? This is gonna indicate also toxicity. We know CNS depression is gonna cause severe respiratory depression also, and it can reduce the respiration rate. What about urine output? Yes, if it is less than 30 ml per hour, what's happening? Because magnesium is usually excreted by kidney, and if we are having less than 30 ml per hour urine, that means magnesium is accumulating in the body. Okay. Okay, so it get accumulated in the body, so it is a good sign of toxicity. And what about blood pressure? 110 to 70. Is this is the desired effect we want from magnesium if it is coming back to normal? Yeah, because we usually give magnesium for the hypertension, like preeclampsia. So this is actually desired effect, so this is not toxicity. Okay. Yeah, no. And what about decreased level of consciousness? Can it cause? Yeah, is yes. Okay, because this is calcium channel blocker also. This is calcium channel antagonist. This is central nervous system depressant. So this medication is gonna cause heap of things like um so we need to say yes to this one. Okay, because it can cause vasodilation, it's gonna block the neuromuscular blocking, so there will be less blood in the head also. Now all the smooth muscles will be relaxed, blood pressure will reduce. Yeah. Okay, question number 16. Yes, go ahead. Question number next. Okay, during active labor, the nurse note late deceleration. Which action should be taken? Because now we have page for an OB. Yeah. So what's gonna happen? Because okay, we have placental insufficiency now. Fetus is not getting the enough oxygen. If we will reposition mother to left side, is it gonna helpful? Yes, because it's gonna move the uterus off from vena cava, and that will improve the blood flow to placenta. So A is definitely yes in that one. Okay, stop oxytocin infusion. What about B? So if when we are giving the oxytocin, what it is helping with? Yes, B. Yeah. Okay, because oxytocin induce contractions, and it can cause contractions, and that can decrease the blood flow to placenta. Yeah. So if we are gonna stop that one, it's gonna reduce the risk of deceleration. Okay, because when there are contractions, it also block the blood flow. And what about administration oxygen? Is supplement oxygen gonna help? Yes, see, definitely. um Let me in place sentence. I need to stop putting. Yeah. C is yes. We need to provide supplement oxygen to mothers, so which can cross the placenta to fetus, and that can reduce the distress. Okay, and is increasing IV fluid gonna help? So if we will increase the preload, is it possible that placental perfusion will also increase? Yes, it will increase. Okay, that will be definitely helpful. And perform amniotomy. Yeah, no to E, no to definitely E. Okay, we don't want to rupture the membranes because it can increase the problem. Okay, let's move to question number 17. We only have 30 questions for today. A patient is in second stage of labor. Which finding indicate progress? So second stage usually initiated when cervix is fully dilated and usually end at the birth of the baby. So involuntary pushing, yeah. ABC, yes. Involuntary pushing is typical sign, a key sign of second stage, because the urge to push, yeah. What about the bulging perineum? Yeah, so B is definitely yes. Okay, because if we are having bulging perineum, it's indicating like the baby's head is descending and it's putting pressure on the perineum. So that's why, yes, that's why it will show the bulge. Okay, and crowning is definite just sign for second stage, because now baby's head is visible in the perineum and does not retract, especially when there are contractions. It does not retract, and if it is visible, definitely, yeah. uh effacement 100%. So if cervix is fully thin, that is pre-requesty, yeah. Yeah, so that's the pre-requesty, like cervix need to be fully thin by that time. So this is good progress. But like here for book club, will it say like that patient is now, because it's 100%, is in now second stage or no? Yes. Okay, so uterine contraction every okay, but like the thing, okay, definitely in real life scenario, we will see not 100% efficient, but in context of question, if the option is there, then we need to choose it. So please don't mind me if I'm taking it yes. Okay, so uterine contraction every 15 minutes. So it's too late, yeah. It should be frequent, yeah. Yeah, okay. So we are gonna cross over E. So it can be more frequent also, sometime 2 minute 3 minute also possible, yeah. 3 to 4 minutes in 10 minutes. Yeah. Okay. The nurse is caring for a patient with epidural anesthesia. Which are nursing priorities? Question number 18. So we are having epidural anesthesia because it's good to use, but it can cause multiple side effects. Yeah. BP. Everyone happy with A? Yes, because it is common side effect and it can also compromise the placental perfusion. So yes, definitely blood pressure. What about bladder distension? Yes, B also. Yeah, because we know why we are giving it. It's to numb, and when epidural can numb the patient's urge to urinate also, and when patient doesn't like pass the urine, it can distend. Okay, just need the foley. Definitely. Position spine with legs straight. What about C, guys? So spine position is indicated or not? It's contraindicated, okay, because this is gonna put pressure on the vena cava. So really we don't wanna that. Okay, so C is wrong. And what about monitoring fetal heart rate? We always do that. D, yes. Latifa, can we elevate? You guys can put on the side also, or with the wedge, under the hip to prevent the vena cava compression. Yeah. So D, yes. And assess for headache after removal. Is it priority? Is E priority? Because we know post-dural puncture headache is a risk, but it's usually assessment. Yeah, it's very common, so it's not priority. Okay, we will definitely assess it. It's top priority after epidural, but the thing is that, like, in this context in question, it's still like epidural in place. There is nothing indicator like whether labor has been finished or not. Yeah, so that's why I'm thinking, because post-dural puncture headache is always risk. So once everything finish, then we will definitely assess that one. Okay. Okay, let's do question number 19. So this is the thing, like even with state exam and NCLEX exams, the thing is that everything can be correct, but we just need to find out within the context of question. And most of the viewers that join here, they are still studying nursing. They are still preparing for NCLEX, so that's why we usually go according to that. But I really appreciate all the comments and help we get from experienced nurse and midwives. It's really great to have those knowledge. Yeah. Okay, so a patient in labor develops shoulder dystocia. Which maneuver are appropriate? So now just G to king, we can E, then A, then D, then C, never B. Yeah. Is it primary? Is E primary maneuver here for book club? Because excessive traction can, contraindicate and can cause nerve damage. Is it possibility of that one? Or but we can do gentle one, yeah. So for the students who doesn't know, if there is a shoulder dystocia, it is usually when the baby shoulder is stuck behind the pubic bone. Okay, so that's now we need to sort out the positions. Okay, nice. Okay, McRobert maneuver. So McRobert, when we are hyperflexing the mother's legs. Okay, because if the pelvis will rotate and widen the outlet, it will help baby to pass. So A, yes. What about B, apply fundal pressure? Is B correct? Do we need to apply fundal pressure or not? No, because if we are applying the fundal pressure, it can cause the uterine rupture also. Okay, so it's always in contraindicated. Yeah. And what about suprapubic pressure? Yeah. So suprapubic pressure actually can help to what we can say, because if we are just applying that pressure above the pubic bone, and it can help to dislodge the anterior shoulder. So this is possible one. Yeah, expulsion of shoulder. Thank you, Bomjan. And what about assist provider with delivery of posterior arm? Because who's provider? Because nurses, it can be doctor, it can be midwife. Yeah, so they use here for book club, they use usually provider, like it can be surgeon who's doing the doctor. Yeah, so we will say D. Thank you, Bomjan. Apply gentle downward traction. So it might be good, but because in NCLEX also safety is always priority, so they don't wanna do that. Okay, it is part of delivery, but it's not primary maneuver according to NCLEX. Okay, so that's why we're gonna say no to this one. Thank you everyone who just followed me. Please search for Nursing on YouTube also and follow there. Really appreciate all your help. Okay. So the nurse recognize uterine tachysystole. Which interventions are appropriate? So we are having now 5 contraction in 10 minutes over a 30-minute period. That's usually the indication of uterine tachysystole. So what we need to do? A, B, C, all but C, yes. Okay, stop oxytocin, because we know this is the one of the medication that is increasing the contractions. Okay, so we wanna stop that one. Administer tocolytics like terbutaline, they can help to relax the uterus. So if there is excessive contraction going on, we can do that. Repositioning patient, if patient especially ABCD, yes. Okay, because it can improve the placental blood flow also. So C is good. Do we need to increase IV fluid? D. Yes. Okay, D is also known to, it can reduce the uterine contraction and placental perfusion. So D is correct. Encourage pushing. So we have already fetal in stress. If we are gonna encourage the pushing, it's gonna increase the, you know, stress. So we don't wanna do that. It's very contraindicated. What is tachyons? Yeah, there is no. This is the only thing we got. Um, So tachysystole is when you have more than 5 contraction in 10 minutes over a 30-minute period. Okay, and when there is too much contraction going on, it can distress the fetus. Um, yeah, and tocolytics are kind of medication like terbutaline that we gave to relax the uterus. Hyperstimulation, yeah, too much movements going on. Okay, guys, let's move to question number 21. We only have 10 questions left for this session, and then we are gonna do renal medication at 10 p.m. New York time, EST. Okay, a nurse assesses a patient 2 hours postpartum with heavy bleeding and bogey uterus. Which interventions are priority? So why we have bogey uterus? Anyone? Why we have bogey uterus? And we know patient is having heavy bleeding also. Blood collection, yes. Okay, we having postpartum hemorrhage, and then there is uterine atony also. Yeah, hypotonia. Yeah, atony, and that's why we are having bogey uterus. Is fundal massage gonna help with that? Is fundal massage gonna help with that? Yes. So it is immediate priority because it can stimulate the uterine contraction, and that can actually reduce the bleeding. Okay, so gentle massage, good. Administer oxytocin. Is oxytocin gonna help with contractions? Yes. Okay, so like we discussed in last few questions, because this is one of the medication that is gonna cause contraction, so it will be priority intervention also. And what about C? Assessing the bladder fullness. C is yes, yeah, because sometimes what happen, like when bladder is too full, that can also prevent uterus not to contract. So emptying the bladder is a essential step in that case, so we're gonna do that. Can we start breastfeeding? What about D, guys? Tahara, it's the thing is that breastfeeding does help to release oxytocin and help with uterine contraction, but it is not immediate high priority because patient is going through active bleeding. Okay, so if we just starting the breastfeeding to release oxytocin, we already administer it from outside, so that's why we're gonna say no to this one actually. Okay, I understand the rationale, we know like why we want to say yes to this one, because it does release oxytocin, it does help with contraction, but it is not one of the priority. Okay, because if baby is there with mother, it can also hinder the other interventions. I have a quick question. In what instant for NCLEX are we checking the cervix? Teddy, there will be heaps of case study around because like these questions are MCQ. You hardly have MCQ in NCLEX. Okay, you need to check for like bleeding, but like what's going on, whether it's fully dilated or not, what is how's assessment. Okay, but the thing is that um, depends what case they can put over there. Most of the people have case, some of the student that I have, they got all the case study from diabetes. Some of the student, they have all case study from meds. Yeah, so everyone have different, but why are you giving that meds postpartum? Nema, NCLEX is exam here for book club. It is exam for nursing that is usually happen in most of the countries like US, Canada, Australia, New Zealand. That's what they refer. We are just giving this medication because uterus is atonic in atony state. Okay, it's bogey uterus. So if you are administering oxytocin, this is gonna help to increase the contraction, and that will help to bring uterus into normal space. Yeah, yeah. Okay, let's administer iron tablet. If we are giving iron tablet, it's not a priority, it's not gonna help, it's oral anyway. Even if something we are giving like that, it's not immediate intervention for active bleeding. Yeah, yeah, in New Zealand also they do have state exam and they call it NCLEX, I think so. I'm not sure, but they do have state exam because I do have some students studying with us for that. Which are the risk factor for postpartum hemorrhage? Well, guys, this is the thing. Like most of the human, Latifa, we do help with NCLEX. This is what we do every day here. We try to solve at least 50 questions every day. Last week it was prioritization and pharma, and this week we are going through topic by topic. Last couple of days we done on cardiovascular diseases, cardiovascular medications. Now we are doing bit of on maternal, and later on we are gonna do on renal disease. Okay, okay, prolonged labor, because we know prolonged labor can cause uterine atony. Olivia, yes, definitely we are live at least 5 days per week. Okay, so we are most of the time here. Okay, this can cause atony, uterine atony, and that can increase the risk of postpartum hemorrhage. So A is definitely yes. What about multiple gestation? So if somebody is having twins, if somebody having triplets, that's definitely gonna increase the risk of bleeding by over distension of uterus. So B is correct. And polyhydramnios, C. So if C, if there is a excessive amniotic fluid, yes. Yeah, because how we discuss like multiple gestations like twin and triplets can increase the uterine over distance the uterus. So that's how, if there is too much polyhydramnios, too much amniotic fluid, then definitely. Okay, uterine atony, D. Yeah, all except asthma. Yes, guys, because this is one of the reason of postpartum hemorrhage. Okay, question number 23. So a nurse is teaching about postpartum infection warning sign which should be reported immediately. Thank you guys, thank you for follow. ABDE, nice Danny, nice. So fever always key sign of infection. Yeah. And what about foul smelling lochia? What about B? Because in normal it is always fleshy, it never had foul odor. So whenever there is a foul odor, there it is signs of infection. And what about C? Breast engorgement. It is expected, it is common sign, it is not sign of infection. No. Yeah. So C is common. Okay, C is common physiological process. I think it usually stay for like maybe 5 days, 5 7, or it can be less, but it's not sign of infection. Okay. And red painful incision site. Margaret, definitely I will DM you. Can you please DM me? We can do another session on NCLEX later on. Yes, D. Okay, this is the classical sign that there is a wound infection going on. What about severe pelvic pain? So if we are having severe pelvic pain, what it is indicating? Yes, endometriosis, infection of uterine lining, retained product. Yes, yeah. E is definitely yes. Okay, now question number 24. So a postpartum patient is experiencing mastitis. Which nursing intervention are appropriate? Yeah, breast tissue inflammation. Yes. Thank you guys for following and sharing. Really appreciate. Please do follow YouTube also. Search nursing on YouTube. All these lives are gonna be uploaded there. Okay, all of these lives are uploaded there. Okay, continue breastfeeding. Yes, just to clear clot infection. Okay, because if there is a milk status that can worse increase the infection. Apply warm compression. We know warm compression gonna help to improve the circulation and milk flow. So B can be yes. Okay. Start prescribed antibiotics. So because this is the keyword in NCLEX also, prescribed or as prescribed. So it's always correct. Most of the time it's correct in NCLEX exams. And what about massage breast vigorously? No. Okay, so D is no. Yeah, because it can cause the injury, it can increase the inflammation and pain. So gentle massage is only recommended, not vigorous one. And wear sporty bra. It will help to reduce the pain. It will help to support the inflamed breast. So is yes. Cool. All good. Let's move to question number 25. So a patient has postpartum depression. Which symptoms are typical? Thank you guys for following. Because this is one of the serious mood disorder and it can happen later after. the pregnancy. So persistent sadness, a very hallmark symptoms, especially after postpartum. So this is gonna be there because in baby blue it can resolve in couple of weeks. Loss of interest in activities. So when somebody is having anhedonia, they don't want to do anything. Yeah, this is also classical sign of depression. So we're gonna see this one. Are we gonna see excessive energy, or are we gonna see someone like lethargic, not coming out? Yeah, no energy at all. They will be like hiding. Difficulty bonding with infant. D. D can be possible, yes, because the patient can feel detached and resentful toward the baby, so that can reduce the bonding with infant. Is E for postpartum psychosis? Thought of harming self or baby. E. Yes, it is, but okay, the thing is that here we're gonna say yes. This is yes because it's about safety, and safety is always priority. Okay, thoughts can be there, guys. This is critical, dangerous. If somebody is having thought, that's always patient safety in nursing is always priority. Okay, because it can be the sign of blaming the baby, why the mother can't do anything, why they gone into depression. So when we start looking into the mental health, we need to make sure what they are thinking. Okay, especially like if somebody is having suicidal ideation also, we need to make sure they are safe. Oh my god, what I have done. Yeah, okay, this is good. Question number 26. A newborn is at risk of hypoglycemia. Which infants are higher risk? Question number 26. ABD, infant of diabetic mother. Yeah. So what can happen with A? Because like if somebody is diabetic, mother is diabetic, then there will be hyperglycemia, and it can increase the fetal insulin production. Okay, so that can cause hypoglycemia after birth when glucose supply is cut off. Yes. Okay, so A is correct. Preterm infant. What about B? B is yes, because the baby just born and they don't have enough glycogen stores. Metabolic regulation is not mature enough, so B is definitely yes, it is possible. What about C, guys? Small for gestational age. Same thing, because if they are small for gestational stage, they don't have glycogen. Okay, they don't have glycogen stores, so they can lead to hypoglycemia easily. Yeah, yes, all except E. All except E, guys, correct. Okay, large for gestational age also, because when they are usually large, it always associated with the maternal diabetes. Thank you, Zeda. Yes, okay, it always sign of maternal diabetes that can lead to the high insulin production, and that can lead to hypoglycemia. So infant with Down syndrome, we know Down syndrome can be associated with other health issues, but like it's not a direct factor related to the hypoglycemia. Okay, so E is no. Yeah, 4 questions left, and then we will finish this session. Alrighty, a nurse is teaching about newborn hypoglycemia symptoms, which are correct. Jitteriness. Can it be the neurological symptoms? Yes, yes. This is one of the classical sign because hypoglycemia is gonna cause neuro irritability. So that's why we will see jitteriness over there. And what about high pitch cry? A B, yeah. So B is also because now baby in stress, nervous system, CNS distress going on over there. So we will see high pitch cry. What about hypotonia? Poor muscle tone. Yeah, again, we need energy for action potential in the muscles. Okay, so now we are having hypoglycemia, we are not having enough energy over there. So that's why we're gonna see hypotonia too. What about seizures? If there is a low blood sugar, can it cause seizure? Yes. Okay, this is also important. If there is too less sugar, it can cause seizure because hypoglycemia gonna affect the CNS. So neuron, contractibility, action potential around neuron also gonna affected with that. And what about flushed skin? E. E no. Yes, E no, because if it is flushed, it is more associated with hyperthermia or high glucose level. Okay, hyperglycemia, hyperthermia, you will see flushed skin, but not with the hypo. Okay, let's move to question number 28. So, a newborn with respiratory distress syndrome may present with which finding? Grunting. A. Yes. So everyone, if we know, like respiratory distress syndrome is usually when we don't have enough surfactant in baby's lung, and that can make it bit more stiff. Okay, G2 King, I will show you that questions. So mechanism grunting, this is main body is trying to keep the alveoli open. So is yes. Nasal flaring. What about nasal flaring? Yeah, physical maneuver to get more air. Yeah. And what about retraction? What about retraction, guys? We're gonna see retraction also because intercostal, subcostal, suprasternal muscles are gonna assist with the breathing. So see, we will see most of the time we're gonna see those in the intercostal and subcostal muscles. And what about bradycardia? Are we gonna see bradycardia or tachycardia? Tachycardia, yes. Okay, so we're gonna have tachycardia, not bradycardia. Okay. Cyanosis. Yeah, yeah. because at initially body is gonna try to compensate, so that's why you will have tachycardia. Later on, when there is not enough fluid, body is going into the hypovolemic shock because too much things going on, then it will go into the bradycardia. Okay, it initial cyanosis, yes, we are having less perfusion, less oxygen, so then there is gonna be blue discoloration. Definitely cyanosis is bluish discoloration due to lack of oxygen. Usually you will see in the peripheral extremities, like hand, nose, lips. Yeah. Okay, question number 29, guys, and make sure everyone go to YouTube and subscribe this, because all of these questions gonna be there. Okay, and I always post shorts and video on that, so please share. So, a nurse is providing care for a newborn with jaundice. Which intervention are appropriate? Two more questions. We're gonna finish at 30. ABCE, yeah. Initiate phototherapy, definitely. This is gonna help because it break down the bilirubin into the skin and then it can be excreted. Okay. Encourage frequent feeding. Again, same thing. If we are encouraging frequent feeding, then there is higher chances of excretion of bilirubin, especially into the stool. So feeding is yes. Monitor bilirubin level. Yeah. Yeah, so we're gonna monitor it, because whether to see whether it's working or not working, whether treatment is effective or not. And what about D? Free keep infant under blanket? No. So, and because baby need to fully exposed to phototherapy lights, so except for diaper and eye shield, so blanket is contraindicated. Okay, so we don't want blanket over there. And what about monitoring urine and stool output? What about E, guys? E is yes? Yes. Okay. Because bilirubin is excreted through urine and through stools, so we need to make sure adequate, if there is adequate output, it's indicating that treatment is working. So E is yes. Okay, last question for this session, and then we will come at 10 p.m. New York time EST with renal disease. I will show you some questions for renal also, but this is our last question, so make sure you guys follow if you haven't followed. Which findings are normal for a newborn assessment? Best of luck. Thank you, really appreciate. Hopefully it was helpful, Nina. Okay, we will go to 29 after this one. Okay, I will definitely go back. Okay, vernix gaseosa. What about A, guys? Because this is one of the cheesy white substance, the layer that we see on the baby skin, especially in the premature. So this is normal, it is protective. Okay, and what about lanugo? So if somebody is having fine hair at back and shoulder, and sometime it can be on forehead also, it depends, but these fine hairs are common. Okay, and it can disappear over the time. And what about acrocyanosis? C. So if somebody is having bluish discoloration around feet and around hands, it's common. Okay, actually acrocyanosis is common, guys. It is common within first 24 hours. Okay, So C is yes. And what about positive Babinski reflex? What is Babinski reflex, guys? D is yes. Toe is flare. Yeah. So when we stroke the sole of foot, toe is fan out. So this is normal newborn reflex. So this is good. And it usually disappear, when nervous system matures. Petish over the chest. What about E? What about E? Petish, we know it's the sign of pinpoint hemorrhage. No, so this is not normal. Okay, this is indicating there is a infection, there is a birth trauma, there is something that require further investigation. So this is not normal. Okay, I'm gonna go to question number 29. Somebody requested that, so you guys can. Okay, so this was us for this session. We're gonna come with renal disease.